Hello, good evening. Welcome to this brand new show called Ask Dr. Saw. In the studio with me is Dr. Saw, and this is the gentleman that I will be asking questions. You, the public, will also have an opportunity at a subsequent time to ask questions because this show will also be a live call-in show sometime in the future, not in the not too distant future. But this is all about asking Dr. Saw, and I want to introduce an amazing doctor that I met a few weeks ago, and I've been blown away by his credentials. But to tell you a little bit about Dr. Saw, nobody best to do it than Dr. Saw himself. Dr. Saw, welcome. This is your show, Ask Dr. Saw. We're going to be asking you a lot of things, but let me ask you first. Tell me a little bit about you. You're Guyanese, of course. You were born here.
Indeed, yes.
And tell me a little bit about you, Dr. Saw.
Thank you for having me and inviting me to this program. So I just give you a little background of myself. Originally, I'm from Barbados, Guyana. I did A-levels at QC, then I went on to do medicine at University of Guyana. Subsequently, I worked at Georgetown Hospital, and then I was the regional health officer for Region 9, that is Letem Rupununi. As you know, in those days, we only had first degree at the University of Guyana. Now, there are postgraduate programs. But I left Guyana in 2000, around that, to further my studies, to do postgraduate training. So I started postgraduate training in surgery. However, in those days, most of the postgraduate, what we call basic and specialized training.
Okay.
So after finishing your basic training, you have to move on to specialized training, and most of the jobs were out of London. I didn't want to move out of London, so I decided to switch career from surgery to general family medicine.
Okay.
So I ended up practicing there for a little while. Then I went on to do my membership at the Royal College of Physicians and membership at the Royal College of General Practitioner. And recently I've been appointed a fellow of the college as well. So I've been coming to Guyana over the years, and I feel that Guyana is always a thought to me. As you know, we are all nostalgic about Guyana. Every Guyanese, I think, we have actually never left Guyana, to be honest. So coming back over the years, I know we are making lots of strides in medical care, and we have moved far away from, but there's a lot more that needed to be done. And I feel that one of the ways of doing that is by doing some medical education, because I think lots of time patients come in to see you and they will go around seeing doctors and not understanding clearly what is wrong with them. There are some conditions you just have to accept that this is what I have and there's no cure for it, and let us try to manage it and live in harmony with it. And I think that really is the focal point of when I try to do education, patients education. I have a keen interest in teaching as well. Okay. So I teach medical students at University College London and Barts University. So, with that in mind, I feel that this is an opportune time for me to come back to Guyana, give something, and I'll probably be here for a little while.
But Doc, let me ask you this. When I saw your card, normally when somebody introduces themselves, you will see Dr. So-and-so, and then you will see MD or whatever the case, or something written at the back. Yours have a lot. Please tell me, what are those? What are your specialties?
Well, as I say, it's difficult. I don't like to blow my own trumpet.
No, but you have to, because I'm sure the public also wants to know who they'll be interfacing with.
Indeed.
And that's that they will want to know that it's somebody who is who's qualified and
indeed, of course,
and capable of answering questions.
Yeah. So I think so your first degree is what is called your MBBS or your MD. So that is Bachelor of Surgery, Bachelor of Medicine. So I left and I went on to do surgery. So I did my member of the Royal College of Surgeon exams. As I said, that was your basic surgical training, and then you move on to specialized training. Then I switched to family medicine, and I got MRC GP. That's a member of the Royal College of General Practitioner. Mm-hmm. Then I went on to do internal medicine, which is member of the Royal College of Physician, MRCP. And then I've got a keen interest in education, and there's that yearning, and I always say in medicine, the deeper you get into medicine, the more you know how much you don't know. Okay. And that prompted me to go on, and I did a postgraduate diploma in cardiology. I did a postgraduate diploma in dermatology, because these are all common things that I see. And if I see a condition and I feel that, hey, I want to increase my competency in an area, I go on to do a some specialization in that. So yeah, so with that little bit, I feel that I have a wide general background in medicine, and I feel competent to really, be in a program where I can navigate. I'm not saying that I know all, but I can navigate most things.
Brilliant. And Doc, this is going to make for interesting conversation, because let me tell you a little bit about myself as it relates to, I have not had even the common cold, I think, in the last 4 years. Not even the common cold. But what I do, I live, some people call it an extreme lifestyle. For instance, I eat one meal a day. There's something called OMAD lifestyle. I think there is one other guy here in Guyana that I know do it. I eat one meal a day. I eat at 6 in the evening. I don't eat anything for the entire day. I have my coffee in the morning, and I drink lots of water all day. I'm 49 years old. I'm running 4 miles in my community in under 40 minutes at my age. I usually run in the hot sun when it's the hottest, and so for me, I also look at the psychological aspect of health and the somewhat spiritual aspect of health also, for instance, meditation and all of these things and how they can help. So I think we are going to be in for some good conversation, because I want to bring that aspect to the table also, and you can also tell me how is it that the two can come together, the medical aspect and these two sides that I'm exploring, and how we can make it an even better conversation for everyone out there who wants to follow what and have a good lifestyle.
Absolutely. I mean, you've raised a couple of things from what you said just now. So when you talk about health, we don't define health as purely the absence of disease, mental and social well-being. So, and even if you look at where medicine has moved on from the days when we just only use tablets, now there are lots of other treatment which we call immunotherapy. And that's really the new thing in medicine, that, immunotherapy is used for lots of conditions, and it has transformed medicine in many ways. And what is immunotherapy? Is really our immune system, is our ability to fight infection. And if we can invoke those parts of our immune system to do it naturally, probably it will work. And I've seen that. I mean, medicine is not just black and white. You take a tablet, you condition it, sort it. If you're not in a mental state of mind and you haven't invoked those chemical responses, the tablet can only go so much. And invoking those chemical responses do the other part of the job. Now, you touch on the diet and your lifestyle, and of course, you look well, you look healthy, and if it works for you, excellent. But bear in mind that whatever we are doing when it comes to lifestyle change, it has to be a gradual process.
Yes, I said mine is a little extreme. It may seem. I encourage no one to just jump onto that.
Correct, because I would say that there are a couple of things in terms of like one meal a day. I don't know your nutrition, how long you can endure that. Possibly, I mean, we know that people who do yoga, these sages.
It's been 6 months on so far.
Yeah, they used to be without food for a long period. So if your body is adapted with that environment, then fair enough. So whatever you do, you have to do it in stages, gradually. Secondly, whatever you do, it has to be long. If it's a lifestyle change, it has to be long term.
Yes.
So you want to do something. So when we look at, one meal a day might not give you the nutrients you want, but you can take some supplements to go on that. You need water, you need fluids in your body, you need all of that. And, so yeah. Brilliant. And we want to see if that translates into good health outcomes. So maybe there are lots of studies being done now with diet, especially with diabetes epidemic, obesity epidemic. The diet and the lifestyle thing is a big deal.
Yeah. Doc, this show is called Ask Dr. SAWH. And today's topic, as you mentioned, that we're going to be talking about diabetes. I'm so happy. I'm so happy to be talking about that, because my father, he died. He's not here anymore, and he had diabetes. There were not lots of people that I know with diabetes. It's and so my first question to you is, what is diabetes? I hear all of this thing about diabetes. Some people say, well, it's the sugar going in your urine. I hear that some people say if you go and pee on the wall and ants go afterwards and follow your urine strain, that means you have diabetes. And there are all these different things. You hear it's sugar in your blood, and then, Doc, what is diabetes?
Excellent question. I think I thought that diabetes would be a relevant topic. The incidence is very high, and of course, it's common in Guyana, and I really want to touch on it because there are lots of misconceptions there about diabetes. So let us talk about a definition. What is really diabetes? So diabetes is elevated blood sugar when the blood sugar in the body is high. So you see that in the blood. But remember, the blood goes through the kidney and it filters into the urine. So if there's high sugar, the kidney has got a threshold where it filters, X amount it can only filter. So if the level is too high in the blood, the kidney can't reabsorb all of it, so some get washed out into the urine, and then you see it in the urine. So diabetes is elevated blood sugar, and I'll go through the causes why you get elevated blood sugar. But the pure definition, really, I was looking for a definition where I can explain it that covers everything. And there's a slide here I want to just touch on a couple of things. Right. So we said when we define diabetes, it's a chronic condition. So chronic meaning it is long-standing. It's a condition that's going to be there for a little while. And it's a metabolic condition. A metabolic condition means it affects all parts of the body, and the metabolism of the body is the way the body burns energy and things like that. And it's characterized by elevated blood sugar. Now, why do you get elevated blood sugar? So there's the problem. Insulin in your body, when the sugar is high, the insulin allows the cells in your body to use the sugar. Now, if you have deficient insulin, so inadequate insulin, or you have insulin but it is not working well, the sugar remains high.
Oh, okay.
So there are two important points to make there. That is, one is that you can is either deficient supply of insulin in the body, so the body doesn't have enough insulin, and insulin is a hormone, as we know. So either you have deficiency or whatever you have is not working well, and that causes the blood sugar to get high. And then that, of course, spill into the urine. So we can say you can have diabetes without it being in the urine necessarily, because there are different degrees of diabetes. You can have mild, which we call pre-diabetes, and then you have a diagnostic criteria. I'll go through that as to, when do we say, yes, we have diabetes here.
Okay, brilliant. Look, I know some young people here in Guyana. I mean, young people in their 40s. And, sometimes when I say, what's happening here? How are you doing? They say, well, I have diabetes. Doc, how prevalent? You've been in Guyana here for, back and forth. You're here for a while now. How prevalent is diabetes in Guyana and worldwide?
Yeah. I mean, I can't give you exact figures in terms of Guyana prevalence, because I just came back and I'm trying to look at some data. But when we look at the global prevalence, it's widespread. I mean, we have about 10.5 global population with diabetes. So you're talking about
10.5%
of the global population with diabetes. Wow. That's massive. And that's in the adult population. When you look at, they say they predicted by 2045, we'll have close to 3/4 billion people with diabetes. Now, that is huge. But here's the important thing. Lots of these people don't know. When in 2021, the US looked at the patients with diabetes, and they found that almost quarter of those diagnosed with diabetes didn't know they have diabetes. Now, that's the thing. If you have a condition and you're not aware of it, and you start having problems due to that disease, because the disease affects organs of the body and it has negative outcomes, sometimes it's too late. By the time you recognize the condition, half of the body is damaged. So you really want to pick it up early. I encourage people to get tested, to see, to check with a doctor, check their blood sugar and its prevalence. I would say ballpark in Guyana, I would think we probably have 10 or even more %, because if we look at a 10.5 global population, Guyana would probably our diet is predominantly starchy diet, and that has an impact and an influence on diabetes. So I would say over 10%. I mean, in the UK population, my population of patients, I've got probably 6% in my cohort, that is patients registered with me. I probably have about 6 patients. But in patients of in Asian origin. So I've got lots of Indians and other patients. When you look at that subgroup, it's well over 10-15%. And simply because our diet, our lifestyle.
Okay.
So I think Guyana prevalence is very high. Yeah.
But look, I hear this all the time. You know that somebody I heard this before. Somebody said, well, you know, if you got type 1, it's not so bad, but if you got type 2, buddy, you're that bad. So how many different types of diabetes are there, and what are type 1 and what type 2, and is it really that they're bad when they get type 2?
No, well, both, I would say. So, yes, most people have type 2 diabetes.
Okay.
Right? There's a majority of patients type 2. So let us explain type 1.
What is the
and type
difference?
2. Yes. So you have type 1 diabetes where it's what we call autoimmune diabetes, mostly where the pancreas is damaged. And the pancreas is damaged, so you don't have insulin in your body. So you need insulin.
Okay.
So that is the definition, really, where type 1, there is no insulin. So you need insulin. It usually occurs in younger patients in first diagnosis, but you can have type 1 in older patients, which we call LADA, LADA. That's latent autoimmune diabetes in adults. So you can get type 1 also at an older age. But predominantly type 1 is in younger people, and those patients, they need insulin, without a doubt, right? In type 2, now that's what majority of patients will have. Probably more than 90% of the patient, they're type 2 diabetes. So type 2 diabetes meaning that your pancreas is producing some insulin, but it is not adequate. Or the insulin that you have in your body is not working well.
Okay.
So in those patients, they don't really need insulin as a first line or the first treatment. We will start with medication to try to optimize the production of insulin or optimize the utilization of insulin in the body. So most of the type 2 diabetes, we will start with tablets. And when after a while, when I explain diabetes to patients, and this is majority of the patients with type 2 diabetes, I say your body produces insulin, and we know when the diagnosis is made, there's not enough insulin in your body to control your sugar. As I say, insulin controls the sugar. So it's a downward trajectory as time goes on. Over a period of time, the body produces and it goes less and less and less over time.
Okay.
Now, in that period, from here to here, can last from the time you started tablets to some type 2 diabetes also, when they've exhausted tablet, they need insulin. So when the production is so minimal or not there, you have to then take insulin. So initially you get a little bit of insulin. So what we do, we try tablets to push that insulin to work better and for the pancreas to produce more. But after a while, no matter how much tablets you give, there's no more the pancreas can produce. So then you have to go on insulin. So type 2 diabetes can be in tablets and insulin. Type 1, however, is mostly insulin.
Oh, wow.
And there are different types of tablets. We'll go through that, and you can do a combination.
And look, you said both of them are dangerous, but which one? Is one
more than the other?
Yes.
Well, I would say yes, in many ways, type 1 diabetes is more serious because you get it in childhood. It will be, imagine you get that at the age 1. And you live to 70, then you've got it 70 years.
Yeah.
But most of type 2 diabetes will develop at an old age, 40, 50s. So your lifespan of that type 2 would be, let's say, 20, 30 years. So when we talk about complications of diabetes, is the duration you've had diabetes for will then start affecting your organs. So yes, and it's the other thing about it, type 1 also, there are higher risk of something called diabetic ketoacidosis, where you go into a coma. So that is more common in type 1. So I would say it is only because you see type 1 a lot in children. So those children, they get diabetes at early age, and then they go on, and it has a big impact on your life.
Well, in that case, though, I mean, if a child has diabetes at, let's say, 1 year old, develop that, and obviously that child at 1 year old may not be able to say what they're feeling and all of that.
Yeah.
So let's talk symptoms. Let's talk symptoms from type 1 symptoms, type 2 symptoms, and how do you How do you diagnose?
Sure, correct. So, okay, so there is a diagnostic criteria which I'll go through with the blood test, but let's talk symptoms. So, we said it for the three P's in diabetes.
Okay.
So, polyuria, polyphagia, and polydipsia. So, polyuria is you want to pee often.
Okay.
That's one of the symptoms.
Right.
It is not that everybody wants to pee, because as you get older, you get prostate problem, you pee a lot, doesn't mean you have diabetes. But you can pick that up, say, right, I'm going to the bathroom often. That is one of the P's. Polyphagia, you're hungry. You're eating more because the sugar in your body is not getting into the blood. So
Your body's calling for food.
your body is calling for food. And polyuria, polyphagia, polydipsia, I said polyuria,
Yeah,
so you go into often, and you're thirsty.
Okay.
So polydipsia, you're thirsty. So dry mouth, you're thirsty. So those are the cardinal features. So the cardinal features would be you're thirsty a lot, you want to pee a lot, passing urine a lot, you're hungry. Now, there are also lots of other complications that would give you symptoms from those complications. So there are patients, their eyesight can be affected, and that
I
is
heard that.
due to diabetes. They can have numbness in their body where they can't feel, so the nerves are affected. That can give you, those are the symptoms. Now, when we look at how do we diagnose it,
Polydipsia.
yeah.
What is polydipsia?
So polydipsia is when you're thirsty.
Oh, that's the one.
Yeah.
Right.
So polydipsia, you're thirsty a lot,
Yeah,
right? So
okay.
polyuria, passing urine. Polyphagia, you're hungry. Polydipsia, you're thirsty.
Okay, great.
Yeah. But as I say, the diagnosis, of course, blood sugar controls everything. Blood sugar controls, your whole energy level. So you could feel weak. You could feel dizziness. So there are loads of symptoms. Almost every symptom can be explained by diabetes. So I wouldn't say there is one thing to say, right, this is the diagnosis. But when we go through the bloods now to make the diagnosis, there's a special criteria that the World Health Organization use to diagnose diabetes. So you have, lots of people talk about, so I'll put that criteria up there, yeah? Now, lots of people talk about blood tests. So you do a blood test and you want to know, is this blood test, my blood test is, let's say, 100 or 200. It is important to know, remember when you eat, your sugar goes up.
Right.
When you're starving, your sugar gets lower. So you have to know when you're doing this blood test to make the diagnosis. So I just want to make that very clear to patients to understand a little bit on the different blood tests. Now, you have what we call a fasting blood test. Fasting blood test means you haven't eaten. So in the morning when you wake up, first thing, you do your blood sugar. That would be your fasting blood test. You haven't eaten. Now then you have, and there's the value for fasting blood tests, as you see on the slide, the previous slide, it says your value should be your normal blood sugar is usually on the 6. We'd say that's a normal blood sugar, 6 millimoles. So I would have to convert these values in they have the UK values, which we use millimoles, and American values, milligram per DL. I think in Ghana we use lots of the American value, which is milligram per DL. So the fasting glucose, to make a diagnosis, it's anything 126 and above. If your fasting blood sugar is over 126, that is that puts you in the diabetic category.
Okay.
So I'll come back to that. So 126 is equal to 7 in UK units. So that's a fasting sugar. The random sugar is when you take the sugar randomly. You've just eaten or you take it any time of the day. And that's 200.
Okay.
So if the sugar is more than 200, that is diabetes. Or in UK, 11.1. That's a random sugar. Now there's another blood test for diabetes. It is called the HbA1c. Now, I really want patients to understand these terms a little bit, because when we talk about control, it is very important to understand what's your sugar like when it's fasting, what's the sugar like when you have eaten, and what's your average sugar over 3 months. So the HbA1c is defined as the average sugar over 3 months. Now, that value, to make a diagnosis, it should be 6.5 and above.
Percent.
And in the UK it would be 48 millimoles, right? So these are different units, but
Right,
they're
right.
equivalent. I just put both values because, of course, I have lots of UK patients who probably look
Yes.
on the show as well. Now, in the old days, we used to do something called a glucose tolerance test, where we give you a sugar load, you drink that, and then 2 hours after, we test your blood sugar. And that used to be the gold standard how we diagnose. That was before we start testing routinely HbA1c and all of that. And that would give you the criteria, and that is more or less like the random glucose. So 200 milligram, if it's that and over, that's diabetes, or 11.1. So the important thing on this, to summarize this slide, is to say that there are different blood tests you can do, that is fasting, random, or your average.
Yeah.
And for each one of them, there's a different value that tells you that you have diabetes.
Doc, we have about we're doing a half an hour program, but we have about 5 minutes more. And I have one more question to ask you related to this, and we're gonna have to do a part 2 of this because we wouldn't be able to cover all of this. But let me ask you one more question. How important it is to treat diabetes, and how does it affect us? How does this disease affect us?
Sure, indeed. So I always say, if we have a disease and it is not having an impact on our life, possibly we live in harmony with it. Not a disease, let's say a condition. You've got gray hair.
Yeah.
I couldn't be bothered about your gray hair because it's not gonna, well, I got gray hair as well. Or I get bald. I wouldn't worry too much about that because it's not gonna affect my organs, and it's gonna have a negative impact on my life.
Part of life.
Absolutely. However, diabetes is totally different.
Yeah.
So it's a condition. When we say it's a metabolic condition, it means it's a condition that affects the whole body. So I normally try to explain to patients I normally try to simplify it so they will remember this. So let's start from the brain. So diabetes affects the brain. How does it affect the brain? It increases your risk of stroke. So the brain has got blood flow, and there are nerves in the brain. There's blood supply to the brain. Diabetes will affect blood flow to the brain. It increases the risk of stroke. There's something called vascular dementia. So if there's poor blood supply to the brain, you can also increase your risk of what we call vascular dementia. It affects your memory.
Okay.
So go down from the brain now, the eyes. Diabetes affects the eyes. So you have something called diabetic retinopathy, where they're bleeding at the back of the eye. So that's why one of the things we do always, every year, a patient with diabetes will have to have eye check. And that's an important part of diabetes management. So we check the eye, ensure there's no bleeding or, what we call hemorrhage or retinopathy. And there's a part of the macula which can be affected as well. These are the light sensitive area in the eye. Coming down to the heart. So starting from the head, we go down, eyes, then we go down to the heart. Diabetes increases your risk of heart attack because it affects the blood flow. It causes increased buildup of plaque. You have less blood to the heart, you increase your risk of heart attack. As you go downward, it affects your kidneys. As you said, there was blood in the urine, the kidney. Sometimes you have what we call, this is a very important one as well. To know that the kidney is affected, we check for protein in the urine. Okay. So when you pass urine and sometimes the urine is frothy, that means there's protein. That's a first sign that there's a complication of diabetes in the kidney.
Okay.
So as a matter of fact, diabetes is one of the biggest causes of chronic kidney disease, patients with kidney failure. Diabetes is a big cause. As you go down to your genitals, it causes erectile dysfunction. And that's another big one where people don't talk about it a lot, but erectile dysfunction, it affects the blood flow. So how it affects blood flow in the brain and the heart, it affects blood flow in the penis. So it affects your erection. As you go down to your nerves, that is your arms and your legs, it affects the nerve, and we have something called diabetic neuropathy. So lots of diabetic patients, something can't feel.
Yeah, they get a cut and they wouldn't know.
They would know, and that's the danger of diabetes as well. So it affects the nerve. And of course, there are other conditions where what we call peripheral vascular disease, the blood flow to the legs, all of that can be affected. So you walk, there's not enough blood flowing in the muscle, you have to stop, take a rest, and walk again. So it has a big impact on your overall body. Now, if you know that there's a disease that is affecting all of this, you want to pick it up early and you want to treat it early.
Yeah.
So
Doc, we are just out of time for this segment, but we're gonna be back here next week and talking much more about diabetes. There's so much more to talk about on diabetes. Anything you'd like to say in closing for this first segment of our show? Ask Dr. Saw.
Well, I must say I'm very happy that I'm here and we can talk about this. It's a very topical issue and it's very prevalent in Guyana. And of course, looking at all the complications and how it affects people, I think it's very important that we go through this. I am very excited about this, to be honest. I'm really excited that we could be talking everything health.
Yes.
As much as I can, and I will try to shed some light, to clarify. There are lots of myths in healthcare generally and in health and diseases. So we'll try to demystify that, break that down into language that people can understand and the public can understand. If I go out of I get too medical in terms of the jargon, ask me to clarify.
I will, because I come from old school also. I know about where I know about my grandfather jarring people and these kind of things. I will raise these things also. Doc, it was a pleasure. On this first segment, we are going to be doing this again. We're going to pick up from where we're leaving off here with diabetes, and I can't wait to ask some other questions that I think that our viewers out there would love to hear. So viewers, thank you for joining us in this our first segment of Ask Dr. Saw. Share this with all your family and friends. It's a good thing for them to know about these about diabetes and many other health topics that we'll be covering throughout this show. Thanks for joining us and see you next week again. Catch you later.
Thank you.